is nutrition, another one is growth chart. And today's moderator, none other than our well-known, renowned endocrinologist, Dr. Kamchand. So along with Jyotsna and as well as Vigneswari Raja. So both they will participate. And Jahanavi also from Bangalore also going to participate. And on behalf of IIT Tennessee, welcome. And in this regard, I want to really appreciate Dr. Rajkumar, and who has done extremely good work for Sangam Medican today. He has conducted and one of the well appreciated and at Monar, and on behalf of IAP TNC, I appreciate Dr. Rajkumar, who has organized, well organized Sangam Medican, and once again welcome sir, welcome Tangavel sir, welcome sir. Sir.
Yeah, I have problem with my Wi-Fi joining through the phone, so maybe may not be sustained.
Okay.
Sorry.
No problem, sir.
Good
Sir,
evening, sir. Thank you very much, sir. Good evening. Regards, sir.
Sir, Dr. Thuru, are you in line? Thuru?
He's in round,
Hello.
sir. Joining.
Thuru, can you, yeah, please take over, Thuru. Yeah.
Thiru? Okay, till Thiru joins.
Yeah, it gives me great pleasure to be welcoming,
yes,
welcoming our Professor Thangavel sir and his team on this series of to be programs. Today we have Dr. Hemchand and the other senior faculty, who I'm very sure we are very eager to listen to them. So without wasting much time, we would request. I'll hand it over to Dr. Thangavel sir and his team. Thank you, sir.
Good evening. Sorry for APTNC functionaries Narendran, Bal Shankar, Somasundaram, Gopal Subramaniam, Narmada, Rajkumar, and Tirumurugan. Special thanks, Tirumurugan. We used to send the series only very late. Within 24 to 48 hours, he'll make the flyer and submit to us. Thank you so much, Thiru, for that. This is a very interesting talk, very interesting topic, growth charts and rainbow of life. Am I audible, Thiru? Audible and visible?
Yeah, audible, sir.
Thiru,
Yeah,
am
you
I
can
audible
proceed,
and
sir. Please, sir.
Okay. So this is the fifth version of Back to Basics B2B IAP. Thanks for the opportunity given to us. Today is an interesting session. Growth charts really is a rainbow of life. Just start with the topics. Like every one of us, including me, would have experienced this clinical situation in our practice. Confident counseling. Many a time, most of the mother will complain that my baby is not at all eating when the child is playing happily around, well-grown child, but they won't agree with us. They won't accept our suggestions. But once you plot on the growth chart, show that your child growth and weight are within the centile, we may be able to convince them. I used it in saying that இனிமே எந்த பீடியாட்ரிஷன் போய் எப்படி சாப்பிடுன்னு சொல்லக்கூடாது, பார்த்துட்டீங்க இல்லையா அப்படின்னு சொல்லி பிடிப்பேன். Sometime we'll have shocking revelations. Suddenly one day, casually, parents may say that, sir, my son is not growing well. You must be seeing his patient right from birth. First time you measure child, use the growth to your surprise, you see that a 9-year-old child is grossly short and obese. Later, diagnosis hypopituitarism is a short stature. Another two more similar situations. Again, you see the baby is constantly on third centile, both in weight and length. When you examine closely, you will find out a murmur. Later diagnosis, atrial septal defect. Third situation, clinically well-looking child. You have been, in a child have been never hospitalized, never had any problem. But you will see that the growth chart, the first time you plot the growth chart at 8 years or 9 years, see that centiles are below third centile. Then you do investigation, ultrasound picks up biopsy, contracted first time diagnosed CKD. Parents will never forgive us. So growth chart will be with us both in happy situation and difficult situation. So we should make it as a habit to plot the growth charts. Pulse for acute emergency, to analyze a problem in acute emergency, pulse comes for help. Same way, growth chart comes for help in ambulatory pediatrics OP practice. Well-child visit is not complete without plotting in the growth chart, followed by development screening, nutrition advice, immunization, picking up asymptomatic illnesses, and safety advice. Among these 6, very, very important is growth and development. And growth, just weighing the child and saying the baby is well. Instead, we have to plot the growth chart. That is how the team has come up with a very detailed discussions is almost in A2 is at all the pediatricians and postgraduates. I'm very happy to introduce Hemchand Prasad. Hemchand Krishna Prasad is from a modern, yes, from Madurai Medical College, had technology under middle career in Madurai Medical College in 2011. Later, he trained many fellowships in foreign countries. Now he is a currently consultant department of gynecology and diabetes at Mehta Hospital. Mehta Hospital. He South Central YAP 2020 growth charts. Many peer-reviewed endocrinology presentations, many keynote addresses. As an MD, he's half my age. I learned a lot of good things from him. Knowledge, wisdom, compassion, organizing ability. This from this,
Sorry to
lot of
interfere,
new
sir.
things I come forward.
Tangavel sir, sorry to interfere. Your voice is
Yes.
breaking.
Ah.
Can you switch off your video and talk, sir? Voice is completely breaking now.
Yeah, better right.
Switch off video and talk, sir.
It help. 1 minute. So upon written the CV slide, things.
Sir, Tangavel sir, ஒண்ணுல வீடியோ switch off பண்ணிடுங்க,
Yes.
off பண்ணிடுங்க. வீடியோ மட்டும் ஆஃப் பண்ணிடுங்க. It'll be, voice will be good.
Switch off. So we learned a lot of things from him because
I think totally.
I think probably we can go on.
Okay, sir.
You
Yes.
can proceed.
Yes.
Hemchand, sir. I
Yeah.
think till sir joins, you can start proceeding,
Yeah,
sir.
I think let's go on.
And you don't know any, he doesn't need any introduction, and you are a person committed endocrinologist, have done a lot, especially in growth monitoring. And over to you, sir, and welcome our faculties also on behalf of our IAP TNSC. Our presidential action plan is going very well, and back to basics also extremely well. It is well appreciated all over India. Welcome to our Hemchand, sir. Over to you, sir.
Thank you so much, sir. I think today's program is crafted in such a way that where there is a lot of continuity in the three talks. We have divided this. The focus of this is on basics, on the importance of measurement of growth, accurate measurement, proper plotting, and right interpretation. I think that is the theme. We are not interested in looking into the newer advances or the recent modifications. We have beautifully divided this into three parts. The first part will focus on measurement. What is the tool to be used? What is the measurement to be used? How to avoid errors? What are the common errors? That will be the focus of the presentation. The second, that will be spoken by Dr. Janvi. The second talk will be by Dr. Vigneshwari on choice of the right charts, plotting it, and identification of growth abnormalities. The third talk will be by Dr. Jyotsna. She will talk about interpretation of the abnormalities on an individual child in a given clinical situation. So there is a continuum in the three presentations. So the first talk will be by Dr. Janvi. Janvi, can you please share your screen and your CV? She's a very brilliant pediatric endocrinologist. She is currently working in Aster MedCity. She's a senior specialist at Aster Children's and Women's Hospital in Whitefield. She has a lot of academic credits, academic achievements to her credit, and she has a lot of interest in Prader-Willi syndrome, and she has done a lot of work in that. Very proud of your achievements, Dr. Janvi. I think you can start off with your talk.
Evening all. I hope I am audible and my slides are visible.
Yeah, can you please increase your voice a little bit?
Yes, sir.
Hemchand, your background noise is something is there.
Okay, I'll off it up. I'll arrange.
Am I audible, sir?
Yeah, please proceed. Yeah.
Good evening all. At the onset, I would like to thank the organizers, IAP TNSC branch, in addition to Dr. S. Thangavelu sir and Hemchand sir, for giving me the opportunity to speak in this esteemed forum. Today we are going to see about growth charts and monitoring of growth. So as pediatricians, we see a lot of children in our clinic and hospital. So sometimes we are checking the anthropometry and sometimes our sisters will check the height, weight and inform us. But are we using the right tool and technique each time? We'll just have a look. So whenever a child comes to our clinic, how frequently should we measure growth? In a child who is less than 2 years of age, the height, weight, and the head circumference should be checked at every vaccination visit. Between 2 to 5 years of age, the same parameters should be checked every 6 monthly. After 5 years of age, in addition to height, weight, BMI and Tanner staging should be done every 6 monthly till 9 years of age and then once a year. So first, now we'll start with the length measurement. So in any child who is below 2 years of age, we will check the length, and this is checked by using an infantometer. So as you can see in the figure, this is the infantometer. It will consist of a horizontal board on which the markings will be present. A fixed headboard will be present and a movable footboard will be present. So it's important that this infantometer is placed on a firm or a rigid hard surface. It should never be placed on a mattress or a soft surface. Now, when we are checking the length of the infant, two providers is essential. One of them will stand at the head end of the patient and the other will stand at the foot end of the patient. So before checking the length, it is essential to remove any head accessories or shoes or socks. The infant should be placed on the infantometer, making sure the head is touching the headboard. It is essential to make sure that the Frankfurt plane, which is the line drawn between the inferior orbital margin and the upper part of the external auditory canal, this should be perpendicular to the ground. You'll see in the upcoming video also. The foot end the heel should be touching the footboard. That is, after the head is placed against the headboard, the second provider will gently compress both the knees so that the toes are pointing upwards and then slide the footboard towards the heel. By this, we will be able to measure the length. The infant can be removed and the length should be measured to the nearest completed centimeter. So we'll go through a video. This is the infantometer. Infantometer should be used to check the length of the infant below 2 years of age. So in order to check the length of the infant, two providers should be there. One of them will be at the head end and the other person will be at the foot end. And we should not have any pad or pen. It should all be kept aside when we are checking the measurement. Now, when we are going to place the infant, any socks or head cap or any rubber band or hair clips should be removed. The child should be in minimal clothing. The child should be placed over the infantometer. So one provider will hold the head and keep it towards touching the headboard, such that the Frankfurt plane, that is the lower border of the inferior orbit and the external auditory canal upper margin, this line is called as the Frankfurt plane. This should be perpendicular to the ground. Now, hand should be at the side of the body. Flex at the knee of the infant so that the heel of the foot touches towards the footboard. The toes should be pointing upwards. After this, the infant can be removed and the measurement should be checked. So it's not just important to know what is the correct way of measuring. We should also know what are the wrong techniques so that we avoid and educate our sisters to avoid such techniques. For example, one provider is checking the infant's length, or the infantometer is kept on a soft surface like a bed or a mattress. Then we are checking infant's length using a paper or an inch tape. The head or the foot is not touching the appropriate boards. Similarly, the toes, if they're pointing straight or horizontally, that is also not correct technique. So next we are going to measurement of the height. For children more than 2 years of age, height will be measured. This is done using a stadiometer. As you can see in this figure, the stadiometer consists of the vertical stand and a movable horizontal board, which will be used to check the height. So in this case also, we can ask the child to come and stand against the vertical board. If it is a smaller child, we may need to have another provider or the help of the parent who will gently take the foot backwards, so that the 4 points, that is the occiput, the shoulder blade, the buttocks, and the heel, this should all touch against the vertical board. It is important that we ensure that both the feet are kept together side by side. This device is called as the stadiometer, which is to measure height. When we are measuring height, you should make sure that the shoes and the socks and any hair clips or ponytails or hair caps. Then, if it's an older child, we can ask them to come and stand against the stadiometer. If it is a younger child, we have to use the help of the parent also, so that the foot is against the stand. So now, when we are checking the 4 points, that is the occiput, the scapula, the buttocks, and the lower part of the heels, should all touch the stand. And then we should hold the chin, Frankfurt plane, the lower border of the inferior orbit, and the external auditory canal is parallel to the ground. Height should be measured here in completed centimeter. So in this case also, it's essential to make sure that the Frankfurt plane is parallel to the ground. And in both the situations, make sure that the final height, that is, it should be recorded in completed height in centimeter. For example, if you're getting a value between 100.2 and 100.3, you should take the 100.2 centimeter completed height in the nearest millimeter. Now, what are the wrong techniques of height measurement in conditions where the hair accessories or the plaited braid or the ponytail is not removed, or the child's 4 point is not touching the vertical board, shoes and socks are not removed? Sometimes we may just mark the height on a wall and measure with an inch tape. That is not the correct technique. Hands should be by the side of the body. Child should not be leaning to one side or the other. So after the measurement of the length or the height, sometimes we may find out that the child is short or tall. We will be finding by plotting the appropriately in the growth chart, which will be explained by my colleagues. In such cases, we would like to go on with segment measurement. So out of that, the first is the upper and the lower segment measurement. The most convenient technique is by measuring the lower segment between the top of the pubic symphysis and the floor. This will give us the lower segment measurement. To calculate the upper segment, we will have to subtract that lower segment measurement from the standing height which we had measured previously. Let's go through this video. If we are measuring the lower segment, we have to measure from the pubic symphysis to the floor. So generally, this will give you the lower segment length. We have to palpate for the pubic symphysis. This may be difficult in obese children. And then we have to keep it up to the end of the floor. So this will give you the lower segment length. So similarly, if you encounter a short or a tall child, you would also want to measure the arm span. How do you measure the arm span? So you should ask the child to stand against the wall and extend both the hands. It should be at right angles to the body. The arms should be at right angles to the body. Now the distance between the tip of both the middle fingers should be measured. A non-stretchable steel tape like the one shown in the figure with markings in millimeter and centimeter should be used. This should also be to the height in the completed centimeter. Now, generally the arm span is shorter than the height in boys before 10 to 11 years of age and in girls before 11 to 14 years of age. After this age, the arm span will exceed the height. Now let's come to the next aspect, which is the measurement of weight. So as you can see, we are going to use the infant weighing scale, electronic weighing machine, to measure the weight of the infants. Just like in an as we saw in the measurement of the length, this weighing scale also should be kept on a hard, rigid surface. Please ensure it's not kept on a mattress or a soft surface. Now always press when the infantometer, when the weighing scale button is pressed, you should be able to see 0 each time, and then make sure some tissue or a light blanket is placed. In case a heavy blanket is used, I will explain how we will minus that weight in the subsequent slide. Now we will have to measure the infant with minimal or no clothing. Ideally, even diapers should not be there. So you have to keep the infant on the weighing machine, wait till the child calms down. Automatically, in most of our weighing machine, we will get the measurement on the digital scale. It will be frozen. That after removing the infant, that weight can be recorded. To check the weight of an infant, we are going to use the electronic weighing machine. Before checking, it should be in 0. In the baby, all the dresses, accessories, cap or mittens or gloves, everything should be removed. Diaper also should ideally be removed. Place the baby over it and check the weight. So wait until the baby stops moving. The value will be frozen on the display. You can record it. Now, suppose imagine the mother is carrying the baby and we are checking the weight on the weighing machine with the mother's weight. Or, for example, in certain conditions where you're not able to expose the baby and you're keeping with a blanket on or so on, in that case, how do we minus that weight so that we get the weight of the baby only? This is called tearing of the scale. It is essential to know this also. So what you should do is, ideally on the weighing machine, place the blanket or any cloth and it may show a weight of that cloth. Now you will have to press the tar button which is present on the weighing machine. Sometimes it may be, depending upon the weighing machine you have in your respective clinic, it may be as NET button also. After pressing that, the weight will again come back to 0. After this, you can place the baby on the weighing machine like how we discussed in the previous slide and record the value. So for older children, we will be using our electronic weighing machine. It should be kept on the floor. In older children also, it is best to check with minimal clothing. Remove the shoes, socks, remove any jackets which are present and check the weight. Each time ensure that the weighing, before checking the weight of an older child, check that it is 0 each time. Now we will go to the measurement of head circumference. So head circumference should be measured with the child ideally sitting on the lap, because that is the most comfortable position for the child. So in this case, any accessories, hair accessories should be removed. The cross tape method should be used and the non-stretchable tape should be used. So cross tape method means, as you can see in this figure, one over the other, and the 0 should be at the lower end. Now a non-stretchable tape should be used because it will give you the accurate reading. You have to pass the tape over the supraorbital margin in the front, that is above the eyebrow, and posteriorly in the occiput, maximum occiput protuberance area, and then measure on the side which is closer to you. Take that measurement. So you can take 3 measurements and average of the 3 measurements in case they are different by millimeters. Now, body mass index is a calculated measurement which will be obtained from the height and weight measurement. It is calculated using the formula weight in kg divided by height in meter squared. Next, we are going to come to the mid-upper arm circumference. This is an age-independent anthropometric measure which is used in to identify either severe acute malnutrition or moderate acute malnutrition. So how is this measured? So ideally, you should first palpate for the shoulder tip. Second, it should always be measured on the left hand. So you should ask the child to flex the elbow at right angles 90 degrees, and then you should measure mark the tip of the elbow. Now run a measuring tape between these two marks and mark the midpoint with a pen. Now ask the child to extend the elbow. The arm should be relaxed at the side of the body. This is very important because if the arm is not relaxed, it can cause a variation in the mid-upper arm circumference. Now, at the point where you have measured, in the extended position of the arm, you will put the measuring tape in the circumference of the arm and calculate the measurement to the nearest 0.1 centimeter. In this also, the cross tape method should be used. A non-stretchable tape should be used. Now, what are the most common mistakes in while measuring mid-upper arm circumferences? Sometimes we may unknowingly measure on the right arm. We may just estimate that this looks like the midpoint, but it is essential to correctly find out the midpoint and then measure. So the tape should not be too tight. That is, the soft tissues are bulging, or the tape should not be so loose that you notice a gap in the area. So next is the measurement of waist circumference. So this is ideally we do it when we are in overweight or obese children. So you can expose the lower part of the chest and the abdomen for this. Palpate the lower rib margin. It is essential to do it. It is helpful to do it on both sides so that you will get a horizontal line. You can mark it with a pen, a short horizontal line at that point. Then you will palpate for the iliac crest. Mark this also. Now run an inch tape between these two measurements and mark the midpoint. Now you have to measure the waist circumference at this point. Before that, you can ask the child to keep the hands over both the shoulders so that this will give you access for the measurement of the waist circumference. Ask them to be relaxed and stand straight. Then run your tape over the circumference of the waist and measure the waist circumference at the end of expiration to the nearest 0.1 centimeter. In some cases, it is also recommended to take 3 values and take the average. So as you have seen, we have seen how to measure the most important measurements which will be required in our day-to-day practice. We will also subsequently see how to plot them in the respective growth charts and how to interpret them. It will be carried forward by my other colleagues. I would like to once again thank the IAP TNSC and my mentors for giving me the opportunity. A special thanks to the nurses who have helped me in shooting these videos. Thank you.
Thank you so much, Janvi. It was such a crisp and a clear presentation. I think you started off with number one, the importance of all pediatricians. We should follow the Indian Academy of Pediatrics recommended growth monitoring guidelines. IAP way back in 2007, almost 18 years back, gave very clear answers on what measurement to take in every child when. In the initial 2 years in every vaccination visit, then it becomes a 6 monthly and then it becomes an annual visit. So annual measurement of the anthropometric measures. You very beautifully summarized how one should take the length, the height, the associated measurements like upper segment, lower segment ratio, weight in young children, older children, head circumference, waist circumference and mid upper arm circumference. And you also very beautifully pointed out the common errors and you gave both a textual as well as a videographic depiction of the measures. I think that's a very valuable learning material. With permission from the organizers, probably we can circulate it also because it will be very useful for all of us to verify our measures. So before we go to the next talk, a quick rapid fire. What do you mean by an accurate measurement?
Yes, sir. So in anthropometry, we call an instrument to be accurate if the measurement will give you the exact true measurement. Like for example, in simple words, if a child's height is 100 centimeter and my measurement, the device gives me a measurement of 99.8 or 100.1 centimeter, then it's almost the true value. Then in that case, I will call it accurate.
Very good. So accuracy has to be ensured both by the measurer, by constantly auditing himself and also checking your gadget, whether the gadget gives a true measure of what it is. What is precision of a measurement?
Precision is nothing but like repeatability. If we are getting the same value on checking multiple times, then the instrument is said to be precise. For example, I'm the child's height, let's take same 100 centimeter, and each time I'm getting 99.8, 99.9 or 100, 100.1, then they are all precise.
Very good. So consistency of the reading is very important. You don't want it to be showing one value in one time and at the same time child comes in the evening and you get a different value. That should, so any measurement should be both accurate as well as precise. And this has to be ensured both by the measurer as well as the gadget you're using to measure. And for a practitioner, do you have any suggestions on how to check the battery of these instruments?
So ideally, we have an Integro 21 anthropometry manual, which gives us the recommendation that the battery will be valid for 4 months, after which the readings will not be accurate. So they recommend like change the battery every 4 months. But maybe in our day-to-day practice, we can recommend that as long as the readings are accurate and precise, we can go ahead. Either, if not, change the battery more frequently.
So the lesson is audit yourself, audit the gadget, and also audit the accuracy in terms of checking the battery as well. And do you recommend, is there any recommendation on calibration of these gadgets?
Yes, so we have to calibrate the infant weighing scale from time to time. In our busy practice, at least let us make sure that we check it once a year. That would be helpful. It's just that each time when you're calibrating the machine, as you're going to on the machine and see the zero, we have set of weights, standardized weights, which is available from the manufacturer. So we can keep a 0.5 kg or 1 kg or a 3 kg and check if the weight is accurate. In that case, the machine is calibrated.
Thank you. And suppose as a practitioner, I encounter a cerebral palsy child whose positioning on the weighing scale is difficult. Do you have any suggestions for me?
So we all see spastic CP and all, we may not be able to calculate the weight. In that case, actually, we have a set of formulas available, published, verified formulas based on the GMFCS category of the CP child, and also taking into account based on the mid-upper arm circumference. So we can easily calculate the mid-upper arm circumference of the child and the age of the child and use these formulas to determine the weight.
So based on the degree of disability, the nutrition as assessed by the mid-upper arm circumference, you have validated equations which are available, which extrapolate and which have been documented to be accurate. So this can be kept as an option. Thank you. And last question to you: in a sick child coming in status who has been weighed long time back, how do you like a practitioner to measure the weight?
So we all know the Broslow tape, and we also have Indian Academy modified Broslow tape is also available, published. We have it published, so we can use that in a emergency situation to identify the weight and go ahead with the treatment.
Thank you. You have given a very valuable information. The Indian Academy of Pediatrics has come up with an Indian version of the Broslow tape, which is available in the net, published in Indian Pediatrics for practitioners to use in their day. It's not commercially available, but it is available, and probably in the days to come, it will be made available for commercial use as well. I think before we go to the next talk, two important messages: that the World Health Organization and Intergrowth are two very, very, very robust study groups who have given very clear messages on how to take care of the instruments and make accurate growth assessments. I think that is one set of guidelines which is very useful for all of us to follow and give a right measurement and a right tool for our patients. And I think it's their right and our responsibility to ensure this happens. Thank you so much, Janvi. It was such a wonderful, simple, crisp and a clear talk. Thank you so much. I invite the second speaker, Dr. Vigneshwari. So we in the first talk, we saw what measurement to take and how to take it. I think that is very important. So we understood the basic B2B point number 1, what to take and how to take. Now, what is the chart that should be used, how to plot it, and how to interpret it? I think that is the second and the key thing to making a proper interpretation of the growth. To talk about that, we have Dr. Vigneshwari. Can you put your CV slide? Dr. Vigneshwari is a very dynamic and a brilliant pediatrician working at Rainbow Hospital. She has lot of work related to growth, and she's graduated from Madras Medical College, and she has done her further training in Kirpak and Mehta multi-speciality hospitals. She has occupied various positions and done a lot of justification, and she has a lot of academic credentials to her credit. Her area of interest includes nutrition, infections, and NICU. And thank you so much, Dr. Vigneshwari, for accepting, and looking forward to your talk. So she is going to teach us how to choose the chart, how to plot it, and how to identify the growth abnormality using the chart. Thank you. Over to you, Vigneshwari. Please unmute yourself.
Sir, am I audible? Sir, am I
Yes,
clear?
you are. Yes, you are.
Yes. Good evening, sirs. I take this opportunity to thank IAP TNSC, Dr. Thangavelu sir, Dr. Hemchand sir for giving me this opportunity. So moving on to my topic is on the proper choice of use of growth charts. So there are so many charts available like WHO charts, IAP charts, Fenton growth charts, intergrowth charts. So it's common for everyone to get confused.
Small interruption. I request all the audience to put their questions on the chat box, which we can take as we are going. Oh, sorry for the interruption.
Yes. So let us keep it simple. IAP has given proper guidelines. So this is the star slide of my presentation. So what growth charts to use? So at birth, we use intergrowth 21 charts, and below 5 years kids, we use IAP modified WHO growth charts. For above 5 years kids, we use pediatrician friendly growth charts. All these charts are the reflection of ICP model, that is infant child puberty model. So what are intergrowth 21 charts? They are the universal standard charts which aims to define optimal fetal and postnatal growth rather than the average growth at birth, unlike few other charts. So this chart is based on a prospective population study involving 60,000 women over 5 continents over 5 years with 2-year follow-up of babies, and still the studies are ongoing. So as we all know, we use blue chart for boys and pink chart for girls. This is the intergrowth 21 chart. This contains its circumference, length, and birth weight. So it contains 5 centers, weight, length, and its circumference on the same page. So IAP modified WHO growth chart. This is a IAP modified WHO growth chart. It contains weight, its circumference, and length. The WHO charts, we have to use separate charts for each parameter. So this contains 4 centers with the corresponding Z scores. First, third, 50th, and 97th centile. Its circumference alone contains only 3 centiles. That is third, 50th, and 97th centile. Weight contains 4 centiles. So we mark weight, its circumference, length, or height on the same page. And on the back side of the chart, we have weight for height. So this is the same chart for girls. So then what is the pediatrician friendly growth chart? So this is the pediatrician friendly growth chart. Why we call it as pediatrician friendly is that it is a single chart for 0 to 18 years. And the new updates are, it has a BMI lookup tool and a MPH calculator on the same page. It contains 7 centile curves. We need not calculate the BMI when a child enters into the OP. Based on the weight and height, directly we can mark on the chart, and we can be able to say whether the child is underweight, overweight, or obese. Similarly, for the MPH calculator, we need not use the target height formula. Directly by knowing the father's height and mother's height, we can join the lines, and with the help of this chart, we'll be able to say the centile, whether the child falls in the normal range. So this is the same pediatrician friendly growth chart which contains a BMI lookup tool and MPH calculator for boys. So on the back side of the pediatrician friendly growth chart, we have a BMI chart. So the orange line is 23rd adult equivalent, which means overweight. The red line is 27th adult equivalent, which means obesity. So let's see few terminologies which we use to categorize the growth. So at birth, AGA, appropriate for gestational age, means between 3rd and 97th centile. SGA means below 3rd centile. LGA is above 97th centile. So moving on to height. If a child less than 5 years falls under less than third centile, we call it as stunting or short stature. Less than 0.1 percentile, rounded off to first percentile, we call it as severe stunting or short stature. Moving on to weight. So when we call it as underweight is less than third centile. Severe underweight when a child falls under less than first percentile. Weight for height less than 2 years. If a child falls less than third centile, we call it as wasting. If a child falls below first centile, we call it as severe wasting. BMI for a child more than 5 years, we call it as overweight when the child is more than 23rd adult equivalent, obese when a child is more than 28 adult equivalent. So what is crossing of two major centiles? So if suppose a child is in the 10th centile, so we are seeing a child less than 1 year, in a 6-month period, if a child is above the 50th centile, we call it as abnormal growth. For infancy, we call it as, we take a period of 6-month period. For more than 1 year kids, we take it for 1 year period. So crossing of two major percentiles within this time period is called as abnormal growth. So the repetition, so in children less than 5 years, above 97 centile BMI, we call it as overweight. Above 99 percentile, we call it as obese. Let's move on to how to plot the growth charts. All girls must have their growth plotted on a pink chart and boys on the blue chart. Always enter the name, date of birth on the chart. Growth is marked with a dot, not a circle or a cross, at the point of intersection of y-axis and x-axis. It is preferred to interpret weight always in conjunction with height and not as an isolated perspective. So in a single page, you will be able to mark the height, length, weight and its circumference. On the back side, we mark the weight for height. It has only 4 percentiles for convenience and it is also expressed in a Z score. By reversing the chart, we are going to plot the weight for height or BMI. When you make subsequent measurements on the same chart, always join the plots by a line, points by a line to know the trend of the growth of the child. Remind the parents of the next growth measurement and explain your findings to them and always reassure them. So moving on to interpretations. So coming on to Intergrowth 21 chart, its circumference, when it is less than third centile, we always alert because according to definition, microcephaly is less than -3 standard deviations. So this corresponds to -2 standard deviation. So when a child's head circumference falls below third centile, we always alert and make further evaluation. More than 97 centile, we call it as macrocephaly. Birth weight less than third centile is small for gestational age. More than 97 centile is large for gestational age. Between third to 97 centile, we call it as appropriate for gestational age. Weight less than third centile, we call it as underweight. Less than first centile, we call it as severe underweight. Height less than third centile, we call it as stunting. And less than first centile, red line, we call it as severe stunting. Interpreting the head circumference, above 97 centile head circumference is called as macrocephaly, and when less than third centile, -2 standard deviation, we always do further evaluation. The weight for height chart, 0 to 5 years, IAP modified WHO chart. So when a child falls below -2 standard deviations on the less than third centile, we call it as wasting. And less than first centile or -3 standard deviation, we call it as severe wasting. More than 99th centile, a child is called as obese. So weight less than third centile alone will not give any interpretation. We always have to correlate with the height. Weight alone is not a single indicator to name. So BMI less than third centile, we call it as thinness. More than 23rd adult equivalent is overweight. More than 27th adult equivalent is obese. So let's move on to BMI lookup tool. When a 10-year-old boy comes to OP with a height measurement of 150 centimeter and a weight of 47 kg, we need not take a calculator or our phone to calculate BMI. Straight away we can plot on the chart and we are able to say that the child is overweight. Similarly, 11-year girl with a height of 140 centimeter and weight of 55 kg, we are able to find out immediately that child is obese. So this BMI lookup tool acts as a very good screening tool for a busy OP practitioner. So let's see how BMI chart and the BMI lookup tool correlates. So 9-year boy with a height of 140 centimeter, weight 55 kg and BMI 28. So when we plot in the BMI chart, the child is BMI is 28. So the child is obese. So based on his height and weight, the child is also gives the similar interpretation. So it's a very good screening tool, but always for the accurate measurements, we need the BMI chart. So the same thing, when the child falls below, we call it as underweight. Above the red line is obese. So mid-parental height. What is mid-parental height and target height? Target height is known as the adjusted mid-parental height. It is calculated by the formula. For boys, we add the maternal and mother's and father's height plus 13 divided by 2. For a girl child, we have to add mother and father's height minus 13 by 2. This height is plotted at 18 years of age on the chart. The target range is 6 centimeters below and above the target height. So let's see it with an example. A 10-year-old girl with a weight 45 kg, height of 140 centimeters, father's height is 165, mother's height is 160. So to calculate the mid-parental height, we had the mother's and father's height. Since it's a girl child, we are subtracting by 13 and dividing the value by 2. This comes to 156 centimeter. So we plot the 18 years, we plot the 156 centimeter on the graph, and plus 6 and minus 6 centimeter above gives the target range, that is the child is expected to attain the growth potential. So similarly, when we calculate with the MPH calculator, we are marking the father's side and mother's side and joining them with a straight line. It gives the similar centile as that of a target range. So both MPH calculator acts as a very good screening tool instead of calculating with the formula in a OPD. So what are the other important aspects? As we said already, crossing 2 major percentiles in a 6 months and crossing 2 major centers in 1 year for kid more than 1 year is pathological. The Growth Charts Committee recommend weight for height to diagnose wasting and obesity in under 5 age group. The word SAM is used when weight for height Z score is less than -3 standard deviation. It should be used beyond 6 months. Moving on to Tanner staging. So SMR staging also plays a very important role in assessing the growth and development of the child. We have to do a SMR staging for all kids above 5 years of age. So let's see it briefly. It contains 5 stages. For female child, stage 1 is breast development pre-adolescent stage. In stage 2, there is a breastbed development. In stage 3, areolar diameter enlarges. There is a secondary mount. In stage 5, the mature female breast. Coming on to pubic hair, there is no pubic hair in stage 1. Sparse, long, straight hair in stage 2. Darker, curling, increased amount of hair in stage 3. Coarse, curly, adult type in stage 4. And extending on to thighs in stage 5. For a male child, when we see stage 1, the pubis, the penis and testis are in the childhood size. In stage 2, there is enlargement of scrotum and testis. Stage 3, penis grows in length and testis continues to enlarge. Stage 4, the penis grows in length, scrotum darkens. And stage 5, it reaches the adult shape. This is the testicular volume. So why it is important? When we have to refer the child to a pediatric endocrinologist based on a SMR. Girls with axillary or pubic hair growth are breastfeeding before 8 years, and in boys with the axillary or pubic hair growth or testicular enlargement before 9 years. Delayed puberty, that is girls without breastfeeding by 14 years or no menarche by 15 years, and boys with no signs of puberty by 16 years of age. And arrest of puberty at the same stage of puberty for more than 2 years. These all needs referral to an endocrinologist. What are the other charts available? So growth velocity charts, Indian waist circumference chart, proportion charts, upper segment to lower segment proportion charts, extended growth charts for NICU follow-up clinics and growth clinics, and extended BMI charts. So a brief thing about a growth velocity chart. Usually third centile, 97 centiles are considered abnormal everywhere in other charts. Coming on to growth velocity chart, x-axis contains the difference in the age of the child and y-axis contains the rate of increase of height. So in a growth velocity chart, 25th centile is considered as a cutoff. So it's marked with a red line. So this is a growth velocity chart for a boy and this is a growth velocity chart for a girl. So let's see it with the example. A 10-year-old girl with type 1 diabetes mellitus. We have been asked to calculate the growth velocity and plot the growth velocity in the chart. So at 9 years, the child's height was 106 centimeters and 10 years, it was 110 centimeters. So in a 1 year difference, the child has increased 4 centimeter in height. So how to plot it in the graph? So if you see in a 1 year, the child has increased 4 centimeter. So the growth velocity is 4 centimeter per year. So where we have to plot? So 9, 10, so 9.5 years we have to plot. When we plot 4 centimeter per year, the child falls below the 25th centile. So the growth velocity is abnormal for this child. So what are the possible causes we have to look out? Celiac disease, hypothyroidism and other endocrine causes. So the 25th centile is a cutoff in the growth velocity chart. So what are the other user-friendly aspects of growth chart? So in IAP modified WHO chart, we are able to plot at a convenient 15-day interval. In a 0 to the weight, height and BMI measurements can be plotted at 6 monthly intervals in 0 to 18-year chart. So it's color coded. Red color indicates obesity in a BMI chart and orange color indicates overweight. So each year is divided into 12 months, not according to the decimal age. Moving on to waist circumference chart. When there is a BMI chart, what is the need of a waist circumference chart? Because waist circumference mainly detects the central adiposity and it predicts the risk of metabolic syndrome, insulin resistance, and cardiovascular disease. BMI does not distinguish between fat and fat-free mass. As Dr. Janvi already says, how to measure the waist circumference. After measuring the waist circumference, we have age and sex-specific charts. So this is the waist circumference chart for Indian boys. So here the 70th centile is taken as a cutoff. In growth velocity, 25th centile is a cutoff. In waist circumference, 70th centile is a cutoff. So any kid falling above the 70th centile need to be evaluated for metabolic syndrome. So what are the other charts available? We have charts for Down syndrome, Turner syndrome, achondroplasia, Noonan syndrome, Russell-Silver syndrome, and Turner syndrome charts specifically for Indian children. So why we have to use syndrome-specific charts? Let's see it with the example. So a 9-year-old boy with Down syndrome with a height of 120 centimeter. So since 9 years, we are going to use the pediatrician-friendly growth chart. So when we mark, the child comes under 120 centimeter. So this looks like a child is having a short stature. But when we plot it in the Down syndrome chart, the child falls in the 25th centile. So it's always recommended to use syndrome specific charts. So let's see common errors we make while plotting the chart. So case 1, 7-year girl with a height of 120 centimeter and weight of 28 kg. The error in this is the child is...
Can you wait, Vigneshwari? Can somebody type the answer on the chat box? What is the mistake in this chart? If people are awake, somebody can try pointing out. Dr. Banuja gets a prize because she has found out the mistake. And Sri Divya gets an extra prize because she has found out another mistake. Go ahead, Vigneshwari.
So it is a girl child, but we have plotted it in the blue chart for the boys. So second case, so 7-year girl with a weight of 28 kg and height of 120 centimeter. What is the error in this chart? So shall I wait, sir?
People are answering very aggressively with right answers. So everybody is following your talk with a lot of energy.
Yes, sir. So we have already said the charts in a growth chart we have to mark always with a dot, not with a cross or a circle. So that is the error in this chart. So second one. So child T's mother has come for HPV vaccination for the first time to a clinic, and they already have a growth chart which has been marked by the previous consultants. So and you plot. So what is the error in this chart?
Karthikeyan is fully active and alert. go ahead.
So the errors we have already said, when we make multiple measurements on the same chart, it's always been asked to join the dots so that we will be able to know the trend of the growth of the child. So we have to join all the dots by a line. So moving on to last case, a 2-year-old boy with a weight of 12 kg and length of 85 centimeters. So what is the error in this chart?
I think Thangavelu sir has to give a gift to Dr. Banuja, Karthikeyan, and yeah. Okay, go ahead.
So as we already said, for any kid less than 5 years, we need to use IAP modified WHO growth chart because there are so much crowding in this area. So we are not able to know exactly the trend and the growth percentile of the child. So when we mark the same child in a IAP modified WHO growth chart, we are able to get a clear picture compared to the previous chart where there is crowding. So for less than 5 years kid, always we use 0 to IAP modified WHO growth charts, and for more than 5 years we use pediatrician friendly growth charts. So as already Dr. Janvi has said, it's just a revision. So well child in a pediatrician clinic less than 2 years, we have to make height, weight and head circumference in every vaccination visit. For 2 to 5 years, height, weight and head circumference every 6 months. And more than 5 years, height, weight, BMI and SMR every 6 months till 9 years and annually thereafter. So for a less than 5-year kid, we are going to use IAP modified WHO chart. For more than 5 years, we are going to use pediatrician friendly charts, 0 to 18 years. So if a child falls in the normal range, that is weight between 3rd to 97 centile, height 3rd to 97 centile, BMI 23rd adult equivalent. So we are going to serially monitor the child. If the child doesn't fall in the normal range, we are going to calculate the height age, weight age, chronological age and bone age and going to evaluate the child for further assessment. So the references are from Growth Monitoring Indian Children IJPP and from IAP textbook of endocrinology. So my sincere acknowledgements to IAP TNSC, Dr. Thangavelu sir, Hemchand sir, Dr. Janvi, Dr. Jyotsna, and especially my husband and kids. So this is the reminder of the talk. So at birth, we are going to use Intergrowth 21 charts. For below 5 years, we are going to use IAP modified WHO growth charts. For above 5 years, pediatrician friendly growth charts. And thank you. Thank you for this opportunity.
Thank you so much, and thank you for such a nice talk, and thank you to the nice audience for such a beautiful interaction. And to just take it forward, she has summarized what chart to use at what age, and she has also very beautifully told us that the BMI lookup tool and MPH calculator are two important innovations of the Indian Academy of Pediatrics to make us plot. She has very beautifully made the various diagnosis based on the growth chart, the identification of the growth abnormality. I think you have to remember that the more the child is deviant from the median, more likely you're going to have an abnormality. That is the key concept. Maybe at the 3rd percentile in terms of height, it may be at the 25th percentile in terms of growth velocity, or it may be at -3 standard deviation or 0.1st percentile in the case of head circumference. I think more you're deviant, the more likely you are going to find a growth abnormality. Similarly, on the other end, 70th percentile would be for waist circumference, 97th percentile would be for tall stature. So I think that master table which Dr. Vigneshwari put in summarizing what is normal and abnormal. So what is for below 5 years, above 5 years, I think that you should have as a ready. You can probably put it once again, Vigneshwari, that master table. Yes, I think that is the key point which all pediatricians must have and identify children with growth abnormalities. Thank you so much. And as we are going through, we'll just ask some quick questions to sum up. Vigneshwari, why is it that one should use the IAP modified WHO charts and not the conventional WHO charts? Are there any specific advantages?
So the advantages with the IAP modified chart that we are able to plot height, weight, its circumference on the same page instead of referring the individual charts for each one of them.
Very good. It makes your work easier. I think that is why it is an IAP modification to IAP is trying its best to make pediatricians plot growth chart. And why is it called pediatrician friendly growth chart?
Because it is very easy to use. We can give a visual representation. When we have a BMI lookup tool and MPH calculator, sir, so we need not look on the calculators or phone. Very readily, we can visually show the parents the child is overweight or underweight and whether the child will fall in the normal target height. So we are able to visually show to them very easily without any calculation and a single chart for a 0 to 18 years.
Great. I think the Indian pediatricians are really blessed because they have IAP, which has given a growth chart which is pediatrician friendly with zero calculation. Absolutely zero calculation. No calculation for MPH, no calculation for BMI, no calculator. Just plot, identify, and take action. Thank you so much. And what if a 1.7-year-old child can stand? Would you still recommend length or would you recommend height?
So for all less than 2-year kids, we always recommend only length because the child may move, the child may not be able to stand properly. And more importantly, the graphs, the charts have been standardized for length. So it's always
Excellent.
preferable to make the child a measurement by length rather than the height, even the child, if the child is able to stand.
Brilliant. I think that's what WHO says we have to follow. There is no argument on that. And has BMI lookup tool made BMI charts obsolete?
Not at all, sir, because BMI lookup tool is a screening tool. For accurate measurement, we have to use only the BMI chart. And BMI lookup tool always complements the BMI chart. It doesn't replace the BMI chart.
And does on the same line, does MPH calculator replace target height calculation?
No, sir, the same answer only. The MPH calculator complements the target height and makes a easy calculation. So for always the exact measurements, we have to go for the target range using the formula. So just the MPH tool or calculator complements the target height calculation.
I think that's a very good point that you have mentioned. I think there are no large-scale studies who have compared the utility of BMI lookup tool and BMI or the MPH calculator and conventional target height calculation. Thank you so much. I think that one of the key messages for you is explain the findings to the parents. I think that is something which all pediatricians should take as a take-home message. You measure it as told by Janvi, you plot it on the right chart as told by Vigneshwari and put it back to the family and tell them what it tells us with spending some time. Thank you so much, Dr. Vigneshwari. So
Thank you, sir.
We saw a very nice presentation on what is the measurement, how to make it by a very lucid talk by Dr. Janvi. Then we had a very good presentation by Dr. Vigneshwari, who told us what chart to use, how to plot it, and how to identify the growth abnormality. Now the third and the crucial point, how to interpret the growth abnormality and arrive at the possible diagnosis. I think that would be the cherry to the cake or icing to the cake. To speak about that, I request Dr. Jyotsna, a good colleague of mine, very brilliant. Please share your screen with CV slide, Dr. Jyotsna. She is currently an associate consultant at Rela Medical Center, pediatric and adolescent endocrinologist. She has done her undergraduation at Kid Park and she has done her DNB at Mehta Hospital and fellowship at Manipal Hospital. Very brilliant person. Over to you, Dr. Jyotsna.
Thank you, sir, for the kind introduction. I hope I'm audible to the audience.
Yes, you are. Yes, you are.
Good evening, everybody. I would like to thank the IAP Tamil Nadu State Chapter for giving me this wonderful opportunity to present on this prestigious forum. I would also like to extend my heartfelt thanks to Dr. Thangavelu sir and Dr. Hemchand sir for guiding me and also giving me this wonderful opportunity. So today's last topic will be on interpretation of growth charts in Indian children. So the topics that I will be covering will be the heightage and weightage plotting and interpreting the growth chart and few case scenarios that we commonly encounter. So few points to remember. Always we have to ask for the date of birth. For children less than 5 years of age, we need to calculate the age in months for plotting on the growth chart. And for children who are above 5 years of age, we have to calculate the age in year and months. And for height and weight, the lowest centile is the third one and the highest centile is the 97th centile. So for a child who has normal growth, the height and weight will be falling anywhere between the 3rd and the 97th centile. The BMI lookup tool, which is available on our IAP charts, can be used for children above 8 years of age, and serial measurements for height and weight are more superior than a single measurement. So wherever possible, it is always good to look at the previous measurements when we are plotting on the growth chart. And the MPH formula, which was already discussed by Dr. Vigneshwari in the previous talk, is just a refresher. The boy's MPH formula is given by the addition of the mother's height plus father's height plus 13 divided by 2. And the girl's height is given by mother's height plus father's height minus 13 divided by 2. However, it is also important to remember that although the MPH percentile calculator is a very useful tool for finding out the MPH centile, it is unreliable in the extremes of height. So how do we derive the heightage and weightage? So what is heightage and what is weightage? The heightage denotes the age of the child with the same average height, and the weightage denotes the age of the child with the same average weight. So how do we plot it on the growth chart? So initially, we plot the height and the weight of the particular child. And when we are going in this particular example, you can see that the height of the child is below the 3rd centile. So we draw a line that is horizontal and it is joining the 50th centile. And from the 50th centile, we will draw a vertical line that is perpendicular to the x-axis, which shows the age in years. So when we draw this line, we get the heightage. And similarly for the weightage, we again draw a horizontal line that is touching the 50th centile. And from the 50th centile, we draw a vertical line touching the age in years on the x-axis. So this will give us the heightage and weightage respectively. And it is important to remember that for a child with a normal growth, the chronological age and the weightage and the heightage are within the 1 year difference. And there is no role for weightage and heightage in a child with normal growth. Going forward, I will be referring to these 3 parameters with their short forms. So we will discuss about a small example of heightage and weightage plotting. Here we have a 10-year, 4-month-old boy with a height of 120 centimeters and weight of 25 kg. So when we plot the height, we can clearly see on the growth chart that the height is below the 3rd centile. And the weight is falling on the 10th centile. So I'm going to plot the heightage for this child. I have drawn a horizontal line that is joining the height to the 50th centile and a vertical line down from the 50th centile to the age in years on the x-axis. Similarly, we can do the same for the weight to derive the weightage. So the weightage and the heightage for this particular child is 6 years and 10 months is the heightage and the weightage is 7 years and 10 months. So clearly from here we can see that this child's chronological age, which is 10 years and 4 months, has a heightage which is much lesser than the chronological age, which is 6 years and 10 months. So how do we interpret heightage and weightage using the growth chart? As we previously discussed, for a child who has a normal growth, the chronological age will be corresponding to the heightage and weightage, and often these are within 1 year difference. And there is no role for heightage and weightage for interpretation of a growth in a normal child. However, it is very useful for children who have undergrowth or overgrowth. So commonly, children who present to us with undergrowth, we need to differentiate between 3 of these particular conditions, which is commonly seen in Indian children, that is malnutrition or systemic illness. So any child that presents with a systemic illness like CKD or with malnutrition, often the chronological age is higher than the heightage and the heightage is higher than the weightage. So clearly from here, we can identify that the weightage is worst affected. In a child who presents with short stature and we are suspecting an endocrine cause for the short stature, the chronological age will be more than the weightage and the weightage will be more than the heightage. So here we can see that the heightage is the worst affected measure. On the other end of the spectrum, we have children who present to us with overgrowth. Nowadays, it is very common to see nutritional obesity in Indian children. So how do we identify whether it is simple nutritional obesity or if there is an underlying pathological cause for the obesity? In children who have nutritional obesity, the weightage is more than the heightage and the heightage is usually slightly higher than the chronological age. However, in a child who has an endocrine cause for the underlying obesity, the weightage is more than the chronological age and the chronological age is more than the heightage. So here we can see that the height age and the weight age are in the opposite directions when the endocrine cause is causing the obesity. In a child presenting with precocious puberty, the height age is often advanced and it is more than the weight age, and the weight age may be slightly more than the chronological age. Also remember, as previously told by Hemchand sir, that we should strongly suspect abnormal growth in a child when the height and the weight are on different sides of the median. It is also very imperative to know about the equivalent Z-score and percentiles. So the 50th centile on the growth chart, it corresponds to 0 Z-score. And the third centile on the growth chart corresponds to -2 standard deviation. And the 97th centile corresponds to +2 standard deviation. So the growth of a normal child will fall between 3rd and the 97th centile, which corresponds to -2 and +2 standard deviation respectively. And when the child has a growth that is falling on the 50th centile, the Z-score will be 0. So the IAP mobile application is available on platforms such as Play Store and Apple Store for free download. And this is the icon for the growth chart application when you search on the Play Store. And once you download this particular application, the first page that occurs will be this one, where you can click on the new child. And after clicking on this screen will appear where you have to select the gender of the child for whom you're checking the growth and the age in years and months. This instead of age in year and months, we can also enter the date of birth of the child. So that will give the current age of the child. And this followed by this, we can enter the anthropometry parameters. And when we click on the weight for height percentile and weight for age percentile, it will take you to the screen that is showing the growth chart and the position of the child's growth on the growth chart. The other advantage of using the IAP mobile application that it also beautifully gives you the Z-score of the particular child's growth. So this is a small video on how to plot a growth chart. So first I'm writing down the date of birth of the child. So this particular child has a chronological age of 8 years and 6 months. This child's weight is 23 kilos. So I am marking it on the growth chart at 23 kilos. So this is falling somewhere on the 25th centile. And the height of this child is 125 centimeters. This is also falling somewhere close to the 25th centile. Next, I am plotting the midparental height. Using the formula, the midparental height is 154.5 centimeter. So I'm marking it with an arrow. And plus or minus 6 from MPH is taken as the target range. And this we are marking it at 18 years of age. So clearly we can see that the MPH is at the 25th centile or close to the 25th centile. So when we use the MPH centile calculator, I am joining the father's height and the mother's height. So after joining, you can identify that this is also again showing you it is close to the 25th centile. So next we will be using the BMI lookup tool to see whether this child has a normal BMI. So the height is on the x-axis and the weight is on the y-axis. So here you can see that, appreciate that it is a normal BMI. Similarly, just to verify if the BMI, using the BMI chart, I am plotting the calculated BMI, that is 14.7 kg per meter square. You can appreciate that it is a normal BMI. So definitely using the BMI lookup tool, it is a very good useful screening tool for BMI to say whether the child is having a normal BMI or not, whether the child is overweight, underweight or obese. Also the MPH calculator, as we saw in the video already, the centiles are close to each other, that is the 25th centile. Moving forward, we'll now discuss few case scenarios. The case one is of a 3-year-old girl child who's brought for regular pediatric checkup. The weight of this child is 13 kilos, height is 94 centimeter, head circumference is 48 centimeter. So we've taken the WHO growth chart for 0 to 5 years. The girl's chart is used. So here you can appreciate that I have marked the height, weight, and head circumference at 36 months. At 36 months, and this is a growth chart of a normal child. And when we turn back the chart, we will have what we call as the weight for height or length chart, where I have plotted using the length on the x-axis and weight on the y-axis. You can appreciate that this child has a normal weight for height. So interpretation is that this child has height, weight, and weight for height all close to the 50th centile. So this is a normal, a child with normal growth. And you can also appreciate that there is no role for heightage and weightage in a child with normal growth. The next case is that of a 2-year-old boy with a weight of 9 kgs and height of 82 centimeter. So here you can see that the height is falling exactly on the 3rd centile and the weight is falling on the 1st centile or -3 standard deviation. And turning back the growth chart, I have plotted the weight for height for this particular child. You can see that the weight for height for this particular child is falling between the 3rd and the 1st centile. And we previously discussed that these two lines, which is the orange line stands for moderate acute malnutrition and the red line stands for severe acute malnutrition. So this child has moderate acute malnutrition as the weight for height falls between the two lines. Going to the next case, a 6-year, 6-month-old girl is brought with complaints of being short noticed by the parents for the past 2 years, and the younger daughter is now taller than the elder daughter. So this is a red flag sign. So the height is measured as 91 centimeters and the weight is measured as 17.5 centimeters. So while plotting, you can clearly see that is way below the 3rd centile for the population. And the weight is somewhat normal. It is between the 3rd and the 97th centile. So we've also calculated the BMI for this particular child and the MPH. So I have plotted the MPH at 18 years. It is corresponding to 153.2 centimeters. And also I have marked the target height range. So interpretation is the height is less than the 3rd centile, the weight is at the 25th centile, and the BMI, which I will be showing you in the next slide, it is above the 27th adult equivalent. And when we plot the height age for this particular child, it is 3 years. So definitely for a child whose chronological age is 6 years and 6 months, the height age is only 3 years, which is very significant. So as a refresher, I am just showing you the MPH percentile calculator. So I have joined the mother's height and the father's height. You can clearly see that it is falling somewhere between the 10 to 25th centile, close to the 25th centile. I have also magnified my plotting on the growth chart per se. Here also you can appreciate that the MPH is falling somewhat close to the 25th centile. This shows the valuable use of this particular MPH centile calculator, which is exclusively available on the Indian growth charts provided by the IAP. So as I previously told you about the BMI being more than the 27th adult equivalent, you can clearly appreciate that this child is not only short, but is also obese. So when we interpret the chronological age with respect to the weightage and height age, you can clearly see that the chronological age of this child is more than the weightage. And the weightage is also more than the height age. So the height is most affected for this particular child. So whenever we deal with a short child showing obesity, we need to think of 3 conditions, which is hypothyroidism, Cushing's syndrome, and growth hormone deficiency. As hypothyroidism is way more common compared to Cushing's syndrome, we have done a thyroid function test, which is a very useful test following the growth chart plotting. So you can clearly appreciate here that child is having an abnormal thyroid function test where the TSH is elevated and free T4 is low. So simply by plotting on the growth chart, we are able to identify or at least come to few differential diagnoses before going in for definitive testing. So case 4. This is a 11-year, 6-month-old boy who's brought with concerns by the mother of being short, and he's the 3rd shortest in class. They feel that he is not as tall in comparison to his peers in school. His height is 128 centimeter. Here on the growth chart, you can appreciate that it is below the 3rd centile. The weight is 24 kg and the BMI is given as follows. The MPH is 158.5 centimeter, which I have marked at 18 years of age, along with the target range. And on the MPH centile calculator, I have marked the father's height and the mother's height and join them by a single line. The height age of this child is 8 years 3 months. So definitely the height age is less than the chronological age. But however, when you compare this height of the child with the MPH centile, he does fall into the target height range. So this is a child with familial short stature. So summarizing the previous few slides that I have shown, a child with normal growth often has the height and the weight generally falling between the 3rd and the 97th centile. A child with familial short stature usually has a height that is below the 3rd centile, but when compared to his parents' height range, that is the mid-parental height range and the target height range, the final height, he will fall into the target height range that is for the child. In a child with CDGP, that is otherwise known as constitutional delay in growth and puberty, so we often see short stature in such children with delayed puberty. They often have their height cruising somewhere along the 3rd centile. But once their puberty starts, they have their height spurt. The puberty is delayed in such children, often seen in boys. And they also have a clear-cut family history of delayed puberty in one of the parents. So once the puberty begins, the growth velocity will increase due to the height spurt. And then the final height will fall into the target range for the particular child. So in endocrine short stature, which I previously discussed, here in this particular example of a child with Cushing syndrome, we can see that the weight of this child is progressively increasing, whereas the height of the child is progressively decreasing. So we have the height and the weight in the opposite directions. So in such children, we should definitely suspect for endocrine causes leading to short stature with or without obesity. So now we are going to overgrowth. Case 5 is a child who's gaining weight rapidly brought by the mother for the treatment of acute gastritis found to have acanthosis nigricans and central obesity. This is a very common scenario that we see in day-to-day practice. So on further questioning, the parents say that the child has been gaining weight only in the past 1 year. However, when we plot the height and weight for this child, you can appreciate that the weight of the child is above the 97th centile. And the height, however, it is above the 50th centile, but it is still normal for the population. And the BMI is calculated, it is coming to 24.5 kg per meter square. So when we are interpreting the weightage and heightage, you can clearly see that the weightage is advanced and it is more than that of the heightage. The heightage is also slightly advanced, but it is more than the chronological age. So this is a typical example of a child with nutritional obesity. I have plotted the BMI on the BMI chart for girls between 5 to 18 years. It is more than the 27th adult equivalent. And subsequently, I've also plotted it on the BMI lookup tool. So pediatricians can first plot it on the BMI lookup tool. And if you want to verify, it is clear-cut given when we do the BMI calculation and plot it on the BMI chart that the child is obese. So coming to the last case scenario, it's an 8-year-old child with complaints of breast development that is noticed from the past 1 year, that is from the 7 years of age. She is less than 8 years of age and hence the breast development has started from 7 years. So that is definitely it qualifies for precocious puberty. On examination, she has stage 3 breast with faint pubic hairs present. The height of this child is 140 centimeter. Here on the growth chart, it is just above the 97th centile. And the weight of this child is 27 kg. And this is between 3rd and the 97th centile. MPH is also calculated, which I have plotted on the 18 years, which is 160 centimeters. And when you definitely see as a visual representation, you can clearly see that the height of this child is above the target range for the child. That is the target height centiles. BMI I have plotted, which is normal for the age. The height age of this particular child, when we plotted on the growth chart, is 10 years and 7 months, which is definitely advanced in comparison to the chronological age. So interpretation is as follows, which is the height age is more than the weightage and the weightage is more than the chronological age. So this child has features of premature sexual maturation. So she's a tall girl with precocious puberty. So the diagnosis for this child would be precocious puberty. So we have to do other investigations such as bone age and ultrasound to diagnose the same. So the take-home points from our presentations would be as follows. The growth charts are an invaluable tool for every pediatrician. Regular use and serial plotting will help in picking up abnormalities on time. Wide number of diagnoses are possible with an easily available, inexpensive tool. And by arriving at these few differential diagnoses, we will be able to focus on specific investigations. And in normal children, definitely it is very helpful for giving reassurance to anxious parents. And definitely it is like it is a representation of the growth of the child. So this is a very important slide, which I previously discussed about. In a normal child, usually the chronological age, height age and weightage are within 1 year range, but there is no role for height age and weightage interpretation in a normal child. In a child with poor growth, that is either due to nutritional cause or systemic illness, the chronological age is usually more than the height age and the height age is more than the weightage. In a child who has short stature due to an underlying endocrine illness, the chronological age is usually more than the weightage and the weightage is more than the height age. In children with overgrowth, due to nutritional obesity, the weightage is more than the height age and the height age is more than the chronological age. In a child with pathological obesity, however, the weightage is more affected than the chronological age and the chronological age is often more than the height age. That is, the height age and the weightage are in the opposite directions. In a child with precocious puberty, the height age is often advanced more than the weightage and the weightage is more than the chronological age. These are my references. Again, I would like to thank the IAP TNSE chapter for giving me this wonderful opportunity and my teachers, Dr. Hemchand sir and Dr. Thangavelu sir, and also my co-presenters, Dr. Vigneshwari ma'am and Dr. Janvi ma'am for providing me the support. And the talk will not be over without thanking the parents and their dear children who actually teach us so much on a day-to-day basis. Thank you so much.
Thank you, Joseph. You can continue the slide sharing. You can just put the last slide of summary of interpretation of abnormal growth. I think that is the most important take home of this whole thing. I think understanding physiology. So in a normal child, chronological age, height age, weightage, both all the three are probably within 1 year as stressed by the speaker. And in undernutrition, either the car doesn't have petrol or the battery is not charged. If it doesn't have petrol, weight is affected more. There is poor growth. The weightage is the least. So it's a probably suggestive of or a systemic disorder or a nutritional deprivation. Whereas the battery is not charged, then your height is affected more than weight. So probably there is poor growth with height affected as the least modality. In overgrowth, if insulin is the culprit, overgrowth, overnutrition, insulin, then you have tall, obese children. And when you have sex hormone as a culprit, height is affected the most, weight is relatively spared. And whenever, as stressed very beautifully by the speaker, height and weight are on two different sides of the median. Height below, weight above, or vice versa, you are looking at some kind of pathological cause in these children. So very beautifully summarized. I think you stress the importance of this height age, weightage concept in identification of undernutrition, overnutrition, tall stature, and how physiology and pathology are kind of a jigsaw puzzle which the growth chart amalgamates and gives you a diagnosis. Thank you so much, Jyotsna. You made a great show. A quick rapid fire questions to you. You stressed it in your presentation, but maybe repeat it once for the benefit of all of us. Is this IAP growth chart app, is it charged or is it free for all of us?
It is a free app that is available for download in both the Play Store, Android mobile, and in Apple Store and iPhones.
Is
So it is
height
free
age,
of cost.
height age, weightage concept, is it flawless or at times it can fool us?
The height age and weightage concept is not flawless, even though it is very useful. It is not of use in children who have normal growth.
Very good. And can normal children cross percentiles?
Yes, sir. Normal children can also cross percentiles. For example, a child who's born HGA can have catch-up growth and therefore cross centiles. However, any child who is rapidly crossing more than 2 centiles at any age should be viewed with caution.
So what would be your advice for a child with isolated weight below the 3rd percentile?
When the weight is less than the 3rd centile with a normal height, the child is said to be underweight and it might be related to the underlying undernutrition. In such children, if they are less than 5 years of age, we need to look for the weight for height. If they are more than 5 years of age, BMI should be calculated.
Very good. So the key message is don't look at weight as an isolated measure. It's a husband and wife relationship between weight and height. So both of them have to be looked together. That's a very important point that you have raised. And what is the normal target range?
So the normal target range is given by mid-parental height plus or minus 6 centimeters.
Very good. I think the previous 8.5 has been shortened now to facilitate an early diagnosis. Any specific situation where Z scores are preferred?
Yes, sir. So Z scores are used for assessing the degree of deviation from normal growth, and hence it also helps in telling us about the severity of the growth abnormality.
Very good. And probably response to an intervention which you would do in terms of action. What do the colors on the growth chart indicate?
So there are several lines with colors on the growth chart. Starting with your growth chart for WHO growth chart between 0 to 5 years of age, we have the orange and the yellow lines. And the yellow lines, they depict the third centile, whereas the red line depicts the first centile. Now going to the pediatrician friendly growth chart, there is a red line for the height which denotes the third centile. So it acts as a line below which we need to take action. Now going to the other lines which are present on the weight for height and the BMI charts. The orange lines in the weight for height depicts the moderate acute malnutrition, whereas the red line depicts the severe acute malnutrition. This is the opposite on the BMI chart where it depicts the overgrowth in the child. So there is a yellow line that depicts the overweight adult equivalent, that is the 23rd adult equivalent, and the red line that stands for obese line, that is the 27th adult equivalent.
Great. I think all the three talks gave very clear and crystal clear and crisp presentations with very simple and clear messages. The first presentation gave a very clear message on please read the WHO manual, calibrate your instruments, use accurate instruments, train the personnel who are doing anthropometric measurements in our setting, recheck whether they are doing it right on and off, and follow the guidelines and follow the IAP growth monitoring guidelines to make the right measurement at the right age. And that's the key messages delivered by Dr. Janvi. The key messages from Dr. Vigneshwari is use the Intergrowth 21 or the IAP modified WHO charts or the pediatrician friendly charts and identify growth abnormalities. And the message from Dr. Jyotsna's talk is please use the concept of height age, understand, spend a lot of time, and every color is very important to put things in the right perspective for the parents. So thank you very much. I hope the back to basics is pushing us back to recheck our own methodology, whether we are doing it right, so that we do the preventive pillar of pediatrics, which is growth monitoring in a very robust way. Thank you very much to IAP TNSE on behalf of all of us for this valuable opportunity. Over to Thangavelu sir. I think we have answered all the questions on the chat box also in our discussion as well as in the thank you.
Thank you, Dr. Hemchand. Thangavelu sir for comments, sir.
Sorry, I could not join earlier because of wife. Am I audible now?
Yes,
Yes, sir. You are, sir. You are, sir.
I could not present the CVs of faculty. In short, following the footsteps of Hemchand, he initiated and stimulated interest in Jyotsna and Janvi to become pediatric endocrinologist. So I'm very happy that we have 3 endocrinologists from our institution. And Vignesh is a very sincere community pediatrician, and she's very popular among her patients. So I just want to introduce them. Unfortunately, because of Wi-Fi issue, I could not do that. Sincere thanks to Hemchand for completely moderating this section. And also, he has given a lot of nice things for the pediatric community. Apps for DKA patients, apps for growth. He showed the concept of parent support group. For diabetic patient, we have WhatsApp group support group for CAH patients, growth disorders. I don't think any pediatrician will complete without involving the patient. So all of us are grateful to him, and we have learned a lot from his young man. So with this, I thank the organizers, thank the IAP TNSE for opportunity and for the wonderful presentation by all the 3 faculty, well moderated by Hemchand.
Thank you, sir. Thank you very much, sir. Dr. Rajendran or
Thank you,
Sir, Dr. Singarodu, sir, for your comments, sir. Okay. Hello. Okay. I think we really had a very enjoyable session, very crisp and very much useful. I think what we probably would benefit would be to go back and listen to it again on the YouTube, which is available. The same lecture is available on the YouTube. So I request all the participants to go back and listen to it and benefit from that. The information here is so condensed and yet so intense. I think one simple session will just not be sufficient. So with that words, I will thank everybody, particularly Processing Thangavellu sir and Dr. Hemchand for trying to make a simple subject complicated and then still making it simple. So thank you very much, sir. Good night.
Good night.
Good night, sir.
Thank
Good
you.
night,
Thank
sir.
you, everybody.
Thank you. Thank you, sir. Thank you. Bye.